Hello everyone. So this is our video for the Flexor Forearm and Palmar hand. I apologize in advance. This is a very dense subject, so this is going to be a little bit of a longer video. But again, this resource is coming to you via the Scrubs team, which is our student collaborative resources for understanding and Brody success. So going through our mission statement, Scrubs is a student-derived initiative that is aiming to develop resources for current and future cohorts that will pass through Brody. Members of Scrubs are participating in a variety of subcommittees, and we're aiming to make resources that offer the perspective of a student who has gone through the course, so that way you can see what we felt would have been helpful at the time. The hope is that this will become a staple of the Brody student body, and if this is a goal that you feel aligns with yours, we would love for you to join the team. So lastly, before we get into material, just a quick disclaimer. As always, this is a student-derived initiative, and while we go through multiple stages of vetting, there is always a potential for an error to arise. If there is ever an error, please go with your course documents. And again, this is a student resource, so it is no way replacing the instruction by the Brody faculty. So with that, let's get on into the material. We're going to start with osteology, and we're going to hit this briefly, but just so that way you can see this in an image. There are two bones of the forearm that you're going to need to know. That is going to be your radius and your ulna. The way that I remember this is the ulna is closer to you, so the U in ulna lets me know that it is on the medial side of the forearm. And this is really, I use the radius and ulna to orient myself at all times when I'm looking at the forearm. So starting with structures, specific structures on the radius that you need to know the radial head, which is located right here, it's this rounded region, and then the styloid process on the distal portion of the radius. It would also be good to know the radial tuberosity, as this radial tuberosity is going to be the insertion of some of the muscles that we have already talked about. Now, if we look at the ulna, on the medial side of the forearm, there are going to be a couple of structures you need to know here. The first is going to be the olecranon. The olecranon is a little bit easier to see on the posterior view, which I'm highlighting now. And then on the other side, anteriorly, you're going to have the coronoid process. And in between the two, you're going to have the trochlear notch. So in between the olecranon and the coronoid process is the trochlear notch, and that is going to allow with articulation with the trochlea. And lastly, just as you had on the radius, you are going to have a small styloid process on the ulna. The last thing I want to point out with this particular osteology is going to be this fibrinous membrane that is in between the two bones, and because it's between the two bones, it is going to be an interosseous membrane. So that interosseous membrane helps keep the radius and ulna together. Now moving on to the osteology of the hand, we're really going to be looking at the bones of the wrist and hand here. So I want to start proximally, and we're going to start from lateral to medial. So lateral, that is going to be an anatomical position, the same side as the thumb. So our most lateral but proximal bone of the wrist is going to be this one that's highlighted now. This is going to be the scaphoid. So if we go from lateral and we work our way medially on this proximal row, we're going to get scaphoid, lunate, then we're going to come over to our triquetrum and then the pisiform. Okay, so you can see those listed right here. And then if we go more distally, again, still going from lateral to medial, so starting most lateral, same side as the thumb, and working our way medially. And I should point out that this is a palmar view, so we're looking down as if we're in anatomical position. You're going to have the trapezium, trapezoid, capitate, and hamate. And the hamate's really distinct because it has this hook, and this is the hook of the hamate. That is also how you can tell the difference between an anterior view, which is what we're looking at here, and a posterior view, because you do not see the hook of the hamate here. Remember, the hook of the hamate is going to be on the medial side of the distal row, so I should see that on the same side as your pinky finger. So I look over here at the pinky finger, and you do not see the hook of the hamate. Right. Last thing that I want to point out, or just a few more things, midline when we're talking about the hand. So we're going to talk about abduction and adduction of the fingers. That is going to be towards the midline of the hand, which is down the third digit, which is this red line on this second image over here. Okay. Now I do want to point out a mnemonic that you can use to memorize the bones of the wrist is going to be some lovers try positions that they can't handle. So this first row is talking about the proximal bones, and you're starting from lateral to medial, so thumb side to pinky side. Another way to remember that is the P here, pinky, right, is on the lateral side. So some lovers try positions, that corresponds to scaphoid, lunate, triquetrum, and pisiform. And then that they can't handle, this is going from lateral to medial. the trapezium, trapezoid, capitate, and hamate. Right. Now, the last thing that I want to point out really quickly is the rest of the bones of the hand. After we get our carpal bones, we're going to go into the metacarpals. So you're going to have 5 of these, 1 for every finger. And then we're going to have your phalanges. So your thumb only has 2 bones of the phalange, but the rest are going to have a proximal, medial, and a distal phalange. All right. So now that we've covered some brief osteology, now to get into the meat of the material, this is going to be the muscles of the forearm, and then we'll later talk about muscles of the hand. So we're going to break the muscles of the forearm down into a couple of regions. We're going to start superficial and then work our way deep. So I want to point out that this is going to be the medial aspect over here on this image, and this is going to be the lateral aspect over here. So this is thumb side, and this over here is going to be pinky side. Now, in the superficial forearm, all of these muscles are originating from a condyle tendon off of the medial epicondyle, and you can actually see that right here in this image. So we're going to start with the pronator teres. The pronator teres is highlighted in yellow here. The pronator teres originates from the common flexor tendon, and it inserts into the middle lateral radius. This muscle, along with most of the other muscles in the superficial forearm, is going to be innervated by the median nerve, and the median nerve contains spinal segment C5 through T1. The action of this muscle is to pronate and flex the arm, or flex the forearm. So that is your pronator teres, highlighted once again in yellow. Next, we're going to have our flexor carpi radialis. So flexor carpi radialis is going to the radial side, and again, the radius is going to be on the thumb side in anatomical position. So the flexor carpi radialis, again, originating from our common flexor tendon, and is inserting onto the base of the second metacarpal. And again, the second metacarpal is once again on the same side as the thumb, if we're looking at midline of the hand. The nerve that is innervating this muscle is your median nerve. Again, most of the muscles of the superficial forearm will be innervated by the median nerve, and its action is going to be to flex and abduct the hand. Okay, so this is radial deviation. So bringing your thumb closer to your forearm on that side. Next, we're going to look at our palmaris longus. The palmaris longus may be absent on the cadavers. This is just an anatomical abnormality, but when present, it is going to be located in the same region as this blue muscle that is highlighted, and that is going to originate, once again, from the common flexor tendon, inserting onto the flexor retinaculum and palmar aponeurosis of the hand. It's innervated by the median nerve, C5 through T1, and it is going to flex the hand and tighten the palmar aponeurosis, which again is just some fibrous tissue in the hand that helps you with grip. Lastly, the last superficial muscle of the flexor forearm is this red muscle here, the flexor carpi ulnaris. The flexor carpi ulnaris originates from the common flexor tendon, inserts onto the pisiform, hamate, and fifth metacarpal, and this specific muscle is innervated by the ulnar nerve. So this is the only muscle in the superficial forearm, flexor forearm, that is innervated by a nerve other than the median nerve. So this nerve is innervated by the ulnar nerve, spinal segment C8 through T1. The action of this muscle is to flex and adduct the hand. So this is going to bring the pinky into midline, so ulnar deviation. Right. One thing I want to point out is this little image over here on the right. This is a way that I use when I'm in lab to identify the muscles in order. If you put your thumb on the medial aspect of your elbow and you just splay your 4 fingers out, this is going to be the rough fiber direction of these 4 muscles. So it's going to start with P for pronator teres, F for flexor carpi radialis, P for palmaris longus, and F for flexor carpi ulnaris. Right, so if you're in lab and you get a question on this on the practical, this is just a really quick way to check yourself and count down P, F, P, F. And you can just mix and match what the muscle is based on this little quick abbreviation. And you can do this on the computer exam as well. All right, so now moving into the muscles of the intermediate forearm. Really, there's only one muscle here that you need to know, and this is going to be the flexor digitorum superficialis. And you're going to have a flexor digitorum profundus, which is going to be a deep muscle. So it makes sense that the first one that you're going to see is the superficialis. And it's going to be indicated by this muscle in blue here. So the function of the flexor digitorum superficialis is going to be to flex the proximal interphalangeal joints. And that's going to be in digits 2 through 5. So in order to do that, it's going to originate from the common flexor tendon, the ulna, and the radius, so the region of the forearm. It's going to insert into the shaft of the middle phalanges 2 through 5. Important to note, it is inserting into the shaft of the middle phalanges, not the distal phalanges, okay, of digits 2 through 5. Innervation is by the medial nerve, C5 through T1, and again, the action is to flex the proximal interphalangeal joints. Now, over here on the right, we have a dissector image, and what I want to point out, something that can come up in lab, is the differentiating the tendons of the flexor digitorum superficialis and the flexor digitorum profundus, which is going to be deep to the superficialis. So when you get into the hand, the muscle belly has long vanished. The muscle belly for this muscle is located in the forearm, but the tendons go all the way to the hand and to the digits. So we said the flexor digitorum superficialis inserts into the shaft of the middle phalanges. So it's going to be stopping right here. This tendon that continues distally all the way to the distal finger, that is going to be the flexor digitorum profundus. And I just want to point this out because this is a very commonly tested subject in lab, and you'll get to that when you get to the hand dissection. Okay, now the last thing we want to look at is the deep muscles of the forearm. The deep muscles of the forearm, there are 3. You're going to have the flexor digitorum profundus, the flexor pollicis longus, and the pronator quadratus. So let's start with the flexor digitorum profundus. We just saw the superficialis, so now we're looking deep to that at the flexor digitorum profundus, which is highlighted in blue. And we can see that these tendons are going to go all the way to the distal phalanges. So the origin for this muscle is on 3/4 of the ulna and interosseous membrane, insertion into the base of the distal phalanges of 2 through 5. Because it is inserting into the distal phalanges, it is now going to flex the distal interphalangeal joints, okay, of digits 2 through 5. Now the innervation of this muscle is a little bit specific. It has split innervation. So the nerves that innervate this muscle is the anterior interosseous nerve is going to innervate the lateral half of this muscle. So it's going to innervate the lateral half, getting these lateral digits. Oh, sorry, lateral is over here on thumb side. So these 2 digits here. The medial part is innervated by the ulnar nerve, okay, which is C8 through T1. So the muscle belly that is innervating the muscle, or sorry, the nerve that is innervating the muscle that is going to contract the pinky finger and your ring finger, that is going to be the ulnar nerve. We'll come back to this later, but this is a big point that the flexor digitorum profundus has split innervation with the anterior interosseous nerve, which is a branch of the median nerve, and the ulnar nerve. Right? Now, moving forward, we're going to look at our flexor pollicis longus. So our flexor pollicis longus is pretty much the mirror of the flexor digitorum profundus, except it is going to be acting on the thumb. So pollicis, remember, is pollex is talking about the thumb. So the origin is going to be the radius and interosseous membrane with insertion into the distal phalanx of the thumb. So it's going to insert up in here. The nerve that is innervating this muscle is the anterior interosseous nerve. Okay, and that is again a branch of the median nerve, C5 through T1. The action of this muscle is going to be to flex the interphalangeal joint of the thumb. Remember that the thumb doesn't have a proximal and distal interphalangeal joint because there are only 2 phalanges in the thumb. Now, last muscle of the deep muscles of the forearm is your pronator quadratus. We saw the pronator arteries, which was up near the elbow. The pronator quadratus is down near the wrist. So here's your pronator quadratus right here. It's going to be the deepest muscle of the anterior compartment of the forearm. Its origin is on the distal fourth of the ulna, inserting onto the distal fourth of the radius. As the name suggests, it is going to pronate the forearm, so it's assisting in pronation of the forearm. The nerve that is innervating this muscle is the anterior interosseous nerve, which again is a branch of the median nerve. So I want to point out that all of these muscles, to some degree, are innervated by the anterior interosseous nerve, which is a branch of the median nerve. So the median nerve is going to branch, and we'll see this later when we're talking about the nerves of the forearm. And the deep component that innervates the deep muscles of the forearm, that is going to be the anterior interosseous nerve. Okay, so we'll look at that in just a moment when we look at the nerves. So here are the nerves of the forearm. We're going to go through these one at a time, but let's start with just the identification, then we'll look at these words over here on the right. So first we have the median nerve coming down through the forearm. Okay, so here goes the median nerve coming down. And then it kind of vanishes here, but we'll follow it on the image to the right, which is a deeper dissection. It is going to give off another nerve that is going to innervate the deep components of the forearm, and then it is going to continue to the hand. Now, over here, we have the ulnar nerve. The ulnar nerve, remember, coming around the medial epicondyle, and it is going to give off 2 components that are going to innervate muscles of the flexor forearm. It is going to hit the deep muscle, the flexor digitorum profundus. Remember doing that medial half, and then it is also going to innervate the flexor carpi ulnaris, which is the only muscle in the superficial compartment or region that is innervated by the ulnar nerve. So then here comes the ulnar nerve following down, and we'll look at the cutaneous branches when we look at the muscles and nerves of the hand. Now looking at a deep region of the forearm, so this is some of the muscles have been removed. We see that the median nerve is coming down, and right here it's giving off a branch. This branch is the anterior interosseous nerve. This anterior interosseous nerve is again innervating the deep muscles of the forearm. Okay, so we see here the median nerve in general. If we look at the median nerve and all of its branches in the forearm, is going to innervate all the muscles of the flexor forearm except for the flexor carpi ulnaris and half of the flexor digitorum profundus. And when it comes to the deep muscles, those are specifically innervated by the anterior interosseous nerve, which is a branch of the median nerve. If you look at the ulnar nerve is not doing a lot of musculature in the forearm. It is going to be doing the flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus. Okay, and what I want to point out is that it will pass superficial to the flexor retinaculum as it's leaving the forearm and getting into the hand. Now, if we're looking at the cutaneous innervation of the forearm, there are really two nerves that I want you to know. The lateral antebrachial cutaneous nerve. This is the continuation of the musculocutaneous nerve. So here we have the musculocutaneous nerve coming down, and then it would give off a cutaneous branch that would innervate this region of the forearm. And then lastly, the medial antebrachial nerve, and this is from the medial cord of the brachial plexus. If you need a review on this, go back to the brachial plexus video. Okay, now we're looking at the arteries of the flexor forearm. This is important because this is really heavily tested in lab. So I'm going to walk through different branch points, and we're going to look at those on the image as well. So the first is we're going to look at the brachial artery. The brachial artery is coming down the anterior compartment, or the anterior aspect of the arm. It is going to give off some superior ulnar collaterals, and so an superior ulnar collateral and an inferior ulnar collateral. So the ulnar collaterals are coming from superior going to inferior before you get to the medial epicondyle. As you come below the medial epicondyle, we're going to see that the ulnar nerve is going to ulnar artery is giving off the anterior and posterior ulnar recurrent arteries. So recurrent arteries are going up, collateral arteries are coming down. The superior and inferior collateral arteries are coming from the brachial artery, and then the recurrent arteries are coming from the ulnar artery, which is a branch of the brachial artery. So let's continue down the brachial artery. Brachial artery is coming down, and right here it bifurcates. So the aspect that is going lateral is going to be your radial artery. The aspect that is coming medially is going to be your ulnar artery. So looking at some of the other branches of the ulnar artery, we already talked about the recurrent arteries coming off the anterior and posterior. I also want to point out right here is a bifurcation that is your common interosseous artery. The common interosseous artery is going to continue, and then is going to branch one more time into an anterior and posterior component. The posterior is going to punch through the interosseous membrane. Okay. Now looking at the radial artery, the only one that I want to point out for the radial artery in the forearm is going to be that it's going to give off a small recurrent branch around the lateral epicondyle. And then lastly, we already pointed out the branches of the common interosseous is the posterior interosseous and anterior interosseous. Remember that the common interosseous artery is a branch of the ulnar artery. This one is one that I would know because it is almost always tagged in lab. So make sure you know the common interosseous artery and the anterior and posterior component. Okay, with that, we're moving from the forearm into the hand. So the hand is going to be divided into 5 compartments, and we're going to talk about the muscles in each compartment on individual slides. So this is going to be our breakdown schematic. So you have 3 compartments that are superficial, and here they're located as blue, orange, and green. This is going to be your Thenar compartment. So the Thenar compartment is going to be associated with the thumb. Your central compartment makes sense, it's in the middle. And then your Hypothenar compartment, which is associated with your medial aspect of your hand or near your little finger. Then you're going to have some compartments that are deep. This is going to be your adductor compartment, located in purple in the image, and then your interosseous compartment, which is going to be in between the metacarpals, so in between the bones, therefore it's named interosseous. So with this in mind, with this general schematic, we're going to go through and break down the muscles that we would expect to find in each one of these compartments. So we're going to start with the thenar compartment. Again, the thenar compartment is going to be related to the thumb, so it is going to be located on the lateral side of the hand. And this specific hand we're looking at an anterior view of the right hand. So if you want to hold out your hand in front of you while you're doing this, that is perfectly acceptable. It's something I would even recommend doing on the exams. So all the nerves, let me point this out in red, all the nerves of the thenar compartment are going to be innervated by the recurrent branch of the median nerve. And again, we're going to go through each one of the nerves individually in a later slide, but know that the recurrent branch of the median nerve innervates all the muscles of the thenar compartment of the hand. So with that in mind, let's go through the individual muscles. We're going to start with the abductor pollicis brevis. The abductor pollicis brevis is located right here. It is going to be one of the most lateral muscles that you will see in the thenar compartment. It originates from the scaphoid and inserts onto the proximal phalanx of the thumb. Now, this nerve, again, is innervated, like all the others in this compartment, by the recurrent branch of the median nerve. Its mechanism is going to be to abduct the thumb and assist in opposition. But its main function is going to be abduction of the thumb. So here it is, once again, abductor pollicis brevis. Right? Now, next we're going to look at the flexor pollicis brevis. It is going to be located more medially than the abductor pollicis brevis. So we found the abductor, and we look right beside it, and right here is our flexor pollicis brevis. So the flexor pollicis brevis is going to originate from the trapezium and insert onto the proximal phalanx of the thumb, again innervated by the recurrent branch of the median nerve, and its main action is going to be to flex the thumb at the metacarpal phalangeal joint. Okay. Now the opponens pollicis is not seen very well in this first image, so we're going to look over here towards the right. I do need to point out that we are now looking at the left hand as opposed to the right hand, so everything is mirrored here. But the opponens is deep to the abductor pollicis brevis and the flexor pollicis brevis, and a little bit laterally. So depending on in lab the orientation you look at, you'll see this muscle either deep to these two muscles, or you'll see it on the lateral aspect of the palmar surface. The opponens pollicis is originating from the trapezium, just like the flexor pollicis brevis, and is inserting into the shaft of the first metacarpal, again innervated by the recurrent branch of the median nerve. I hope you've got at this point that it is very important to know that all the muscles of the thenar compartment are innervated by the recurrent branch of the median nerve, and its action is going to be to oppose the thumb. Okay, so those are your three muscles that you need to know for the thenar compartment of the hand. And we're going to keep going. We're now looking at the hypothenar compartment. The hypothenar compartment is associated with the little finger, and what I really want to point out here is that you have basically a mirror image of your thumb, okay, but it's just on the opposite side. So all the muscles here are innervated by the deep branch of the ulnar nerve. So one more time, all the muscles are innervated by the deep branch of the ulnar nerve. Okay, so now going into the muscles. First, we're going to talk about the abductor digiti minimi. So the abductor digiti minimi is going to be located right here. And again, this is going to be one of the most lateral muscles that you're going to see. And the, medial muscles you're going to see in this hypothenar compartment of the thumb, of the pinky finger. So, where does it originate? Originate from the pisiform bone. It is going to insert onto the proximal phalanx of the fifth digit. This is really just a mirror image of the abductor pollicis, but now we're looking at the abductor digiti minimi. Nerve, one more time, deep branch of the ulnar nerve. I think this is really easy that we associate a nerve with the thenar compartment and we associate a nerve with the hypothenar compartment. And then we just think about those as being mirror images. And then the action of this muscle is going to be to abduct the fifth digit at the metacarpal phalangeal joint. Now, the flexor digiti minimi is going to be located in the more central compartment as opposed to the abductor digiti minimi, just like we saw on the thenar side. So right here is going to be the flexor digiti minimi. Okay, so it is originated from the hamate and inserting into the proximal phalanx of the fifth digit, again innervated by the deep branch of the ulnar nerve. Its action is going to be to flex the fifth digit at the metacarpal phalangeal joint. Lastly, we have the opponens digiti minimi. You can see it right here. And again, it is going to be deep to the abductor and the flexor. So there goes the opponens right there. It's originating from the hamate and inserting into the shaft of the fifth metacarpal. Its nervous innervation is the deep branch of the ulnar nerve, same as all of the all of the muscles in this compartment. And its action is to oppose the little finger. Okay, so that takes you through all the muscles of the hypothenar compartment. Now we're going to look at the central compartment. So looking at the muscles of the central compartment, we're going to look at the lumbricals. So the lumbricals are located right here. So I do need to point out that this is a deeper dissection than if you're just looking at the surface of the palm. But the lumbricals are originating from the tendon of the flexor digitorum profundus. So you're actually looking at the tendons that were coming from the forearm, and on the side of those tendons, you have these small muscles. These are your lumbricals. Okay, you're going to have 4 of these. They are going to originate from the tendons of the flexor digitorum profundus, which again goes to digits 2 through 5. So that means that they're only originating from those tendons, so they're only going to act on those same digits, 2 through 5. They will insert into the extensor expansions of digits 2 through 5, and its action is going to be to flex at the metacarpal phalangeal joint and extend the interphalangeal joints. So it'll be flexing at these joints, extending distally. Now, just like we had with prior muscles we've talked about, there is a split innervation you need to know. The medial lumbricals, so the ones on the pinky side, so this lumbrical here and this lumbrical here, are going to be innervated by the ulnar nerve. Okay, so the medial 2 lumbricals are innervated by the ulnar nerve. The lateral 2 lumbricals, so lumbricals here and here, are going to be innervated by the median nerve. So pinky side, ulnar nerve, thumb side, median nerve. That is a trend that we've seen throughout all of this video and we'll continue to see. And again, the action is to flex at the metacarpal phalangeal joints and extend at the interphalangeal joints. And here, down here at the bottom, is just another image that you can use if this first image is a little bit too busy for you. Okay, now we're looking a little bit deeper. We're going to look at the muscle of the adductor compartment. The only muscle in the adductor compartment is the adductor pollicis. So, as the name implies, the overall function is going to be the adduct, the thumb. Okay, so adductor pollicis. We're originating from the base of the second and third metacarpals for the oblique head and the shaft for the transverse head. So you say, Ryan, what do you mean an oblique and a transverse head? So let's look over here at the image. Right here is, so this entire muscle is the adductor pollicis. Well, we can see that there's going to be 2 different fiber directions. Some of the fibers are going to be coming straight across, that is transverse, and some of these fibers are going to be coming up and laterally. So this is going to be obliquely. So that is the 2 different heads of the adductor pollicis, the transverse head and the oblique head. Okay, so this muscle will insert into the proximal phalanx of the thumb, and it is innervated by the deep branch of the ulnar nerve. I want to point out the deep branch of the ulnar nerve is a recurring theme as well. Most of the muscles of the hand will be innervated by the deep branch of the ulnar nerve. And lastly, the action, as we would expect, is to adduct the thumb. So one more time, here's the muscle here, as bordered. It has 2 different components. It has the transverse head, and it has the oblique head. Innervation is by the deep branch of the ulnar nerve. Lastly, we have our interosseous muscles. So the interosseous muscles are going to be the muscles in the interosseous compartment. And again, right here in red, all muscles are innervated by the deep branch of the ulnar nerve. So if you had to guess on a random muscle in the hand, deep branch of the ulnar nerve is your best bet as long as you're not looking at the Thenar compartment. Okay, so that's just a general trend. So looking at the muscles of the interosseous compartment, you have your palmar interosseous muscles and your dorsal interosseous muscles. So as this would imply, the palmar interosseous muscles are going to be seen on the palmar aspect, very deep, and then your dorsal interosseous muscles will be seen on the dorsal aspect. So let's start with the palmar interosseous muscles, and there will be 3 of these. So you're going to see that over here on this bottom right image. They are going to originate from the 2nd and 4th and 5th metacarpals and insert onto the extensor expansions of the proximal phalanx of digits 2, 4, and 5. So digits 2, digits 4, and digits 5. The function of these muscles is going to be to adduct the digits of the hand. So when we're talking about adduction of the digits, we're talking about to the midline. So the midline is this green line that's drawn down the middle of the 3rd digit. So adduction is going to bring those digits towards the midline. Okay, so you only need 3 because you need 1, 2, 3 digits to get towards midline. And so the way that you remember this is pad. So palmar, interosseous, adduct the digits. Palmar, interosseous, adduct the digits. Now we're going to look at the dorsal interosseous muscles. The dorsal interosseous muscles, there are going to be 4 of these. They're going to originate from adjacent metacarpals, so in between the metacarpals. So here's 1, 2, 3, and 4. Their function is going to be to abduct, abduct the digits. So dorsal interosseous, abduct. So it's the difference between pad, so palmar, adduct, and then dab, dorsal abduct. Now, in order to achieve this function, they have to insert into the extensor expansions and the proximal phalanx of digits 2 through 4. All right, and then once again, all of these muscles, the dorsal interosseous, or dorsal interossei and the palmar interossei, are all innervated by the deep branch of the ulnar nerve. Okay, getting into the nerves of the palmar hand. So, the 2 main nerves of the palmar hand that you're going to be keeping up with are the median nerve and its branches, and the ulnar nerve and the branches of the ulnar nerve. So let's start with the median nerve. The median nerve is going to get to the hand on the lateral side, and it's going to go through the carpal tunnel. Okay, so the median nerve is innervating the hand via the continuation of the median nerve and the recurrent branch of the median nerve. So let's see here. We have the median nerve coming through, and then right here it's going to give off a branch that's coming backwards. So this branch that comes backwards, right here that's being highlighted, is the recurrent branch of the median nerve. That is going to innervate the muscular compartment of the thenar region. So everything in the thenar compartment is being innervated by this recurrent branch of the median nerve, a nerve that is almost guaranteed to be tagged on the lab exam. Okay, and then the continuation of the median nerve is going to be hitting the first and second lumbricals, because again, those are located on the thumb side of the hand. Remember, the lumbricals have split innervation. The first 2, located near the thumb, are going to be innervated by the median nerve, and then the second 2 are going to be innervated by the ulnar nerve. So when we look at the ulnar nerve, again, the ulnar nerve is innervating the majority of the hand, but it's going to have 2 branches. It's going to have a superficial branch, which we see on this bottom image, and a deep branch. The deep branch is doing the majority of the muscles. The superficial branch will do one muscle, which we haven't talked about, which is your palmaris brevis. But the deep branch is doing all of the remaining muscles of the hand that haven't been mentioned in association with the median nerve. Okay, so when in doubt, as long as you're not talking about the compartments of the thumb and the first 2 lumbricals, all the other muscles of the hand are going to be innervated in general by the deep branch of the ulnar nerve. Now, the ulnar nerve does a lot of the muscular innervation as opposed to the median nerve. But when we look at the cutaneous innervation, that trend is actually going to flip. The median nerve is going to do more of the cutaneous innervation than the ulnar nerve will. So the median nerve has 2 different branches that will do cutaneous innervation. You'll have a palmar branch, and you'll have some digital branches. The palmar branch is going to do, like it says, regions of the palm, and then the digital branches are going to go down to the digits. So I want to point out that the cutaneous innervation supplied by the median nerve is indicated in purple here. We notice that there's some palmar regions and there's some digits. Important to note that the cutaneous innervation of the median nerve includes the lateral 3.5 digits. So 1, 2, 3, and half of your 4th digit. So the lateral aspect of your 4th digit is going to be innervated by the median nerve, whereas the medial aspect over here is going to be innervated by your ulnar nerve. Okay, so the ulnar nerve distribution is indicated by this light blue, right? We can see that the ulnar nerve has branches that are palmar and dorsal cutaneous branches, which is why we see it on the back of the hand as well. And then it's going to have superficial branches, which are going to go down to the digits via digital branches to innervate the medial 1.5 digits. Really important points. 3.5 digits supplied by the median nerve, 1.5 digits supplied by the ulnar nerve. All right, now we're going to be looking at the arteries of the palmar hand. First, we're going to look at the branches of the ulnar artery. So the ulnar artery is going to come on the same side as the ulna, so that's going to be on the pinky side. So that will be coming through right here. Okay, so when we're looking at the branches of the ulnar artery, there is going to be a branch that is going to go deep, right? So deep meaning like really deep into the hand, whereas there's another branch that comes superficial. Both of these are going to be forming arches. So you have a deep palmar branch that's contributing to the deep palmar arch, and you have a superficial branch that is going to form the superficial palmar arch. Okay, now off of the ulnar artery, you're going to get branches that are going to the digits that are going to hit the medial 3.5 digits. So digit 1, 2, 3, and a half. Now looking at the radial artery, the radial artery is coming down on the thumb side. This is usually where you're going to be checking for a pulse. So the radial artery comes down, and it is going to give off a couple of different branches we need to know. First, there's this branch here that is going to go superficially, and it's going to contribute to the superficial palmar arch, which we mentioned briefly before. So superficially, contributing to the superficial palmar arch. The remainder of the artery is going to go posterior to the thumb, right? And then it will emerge between the interosseous muscles to come back anteriorly. Now, it is going to give off, at this point, it's going to give off a couple of branches that we need to know. The first is going to be this branch coming up towards the thumb. That is your principus pollicis branch, which is why if you feel your thumb, you might can feel a pulse there. And when we don't use our thumb when we're checking for a pulse in patients. Then we see this branch coming up near our index finger. This is going to be the radialis indicis branch coming right here. Now the remainder of the radial artery is going to continue as part of the deep palmar arch. Okay, so big important points to know. You have a superficial palmar arch, and you have a deep palmar arch. It is formed by contributions of both the ulnar and radial arteries. Two important arteries to know from the radial artery are going to be your principus pollicis and then your radialis indicis. All right, and if you need more time with this, there are good images on Google that you can look at that go into a little bit more depth than what we're seeing here. All right, now for some clinical anatomy. This is probably the most important component of this material, so we're going to go slow, but I am going to recommend that you go back over this a few more times on your own once we cover this. So the first thing that we're going to look at is going to be lesions to the median nerve. Now, this is an image from Amboss, and I think it does a great job of covering some of the concepts we've mentioned before. This breaks down the median nerve into its different branches. It says what muscles are innervated by the branch or what is the cutaneous distribution. So what we can point out here is region 1, right? This is the main median nerve. It is going to have components that are going to innervate all of the things that are listed here. So if we have a lesion up here, or we damage the nerve at this location, we're going to lose everything downstream. Whereas if I come down a little bit further, right here is the anterior interosseous nerve. So if I have a lesion that's distal to that, so right here where the red arrow or red dot is indicating, then everything innervated by the anterior interosseous nerve, okay, so everything listed here, will be perfectly intact. There'll be no damage there. I'll only damage everything distally on the median nerve. So we're not going to spend a whole lot of time with this image, but I just want to point that out. This is a really good image to come back to as you're studying and just test yourself. If I damage at this location, what do I lose? If I damage distally, what am I going to lose at that point? And you can work your way down for every single level of the nerve. And what you want to do after that is not just saying what muscles do I lose, but because I lose, for instance, the pronator teres, and that means I'm no longer going to be able to pronate the forearm. Okay, so associating an action with the damage that you're going to find. But to look at that specifically, we're going to look at what happens with specific damage at different regions. So, looking at two that your course pack points out, we're going to look at a proximal medial nerve damage and distal median nerve damage. Proximal median nerve damage is going to be referring to above the anterior interosseous nerve. So this, if you look at the previous image, this is a damage that happens higher up. So what do you lose here if you damage the median nerve above the anterior interosseous branch? That means you're going to lose the long flexors of the first and third digits, the Thenar muscles, the lateral lumbricals, and the proximal flexion of the fourth and fifth digits. So that's all your motor loss. The sensation loss that you're going to have is going to be sensation to the lateral palm and digits 3 through 5. So you're going to lose sensation to this region right here, and you're losing a lot of the motor innervation to this lateral aspect of the palm and hand. So if you ask a patient with proximal medial nerve damage lesion to make a fist, you are going to get this presentation here. This is called the hand of benediction, and this is again occurring when a patient is trying to make a fist. And this is due to the loss of motor function that is listed over here on the left. So if this is confusing to you, I suggest that you take time to go through individually what muscles are no longer receiving innervation, and then how does loss of that function result in the hand of benediction. Next, we're going to look at a distal median nerve lesion. So this is below the anterior interosseous nerve. So if it's below the anterior interosseous nerve origin, then this means that the anterior interosseous nerve is functionally perfectly fine. That means all of your deep muscles of the forearm are intact. Okay, so that means that the only loss is going to be the Thenar muscles. Remember, because those are innervated by the recurrent branch of the median nerve, which is no longer getting to the hand. The lateral lumbricals, which again is innervated by the median nerve, and the sensory information to the lateral 3.5 digits. So if you ask a patient to extend their fingers in this case, they will not be able to, and they'll get this median claw. You can also get what we call ape hand, and that's going to be because there's going to be deterioration of the Thenar compartment because it's no longer receiving innervation. And I recommend looking up some images for that if you want some further clarification. All right, now we're moving into the ulnar nerve lesions. So just like before, this is a really good slide to come back to and test yourself what would happen if I damage at point 1, point 1A, 1B, 2, 3. Doesn't matter, just test yourself as you're walking your way down, and then you can see what muscle and sensory loss would be deficient with a damage to each region. So we're not going to spend a whole lot of time on this particular image. I just think this puts everything really grouped together nicely so you can come back and test yourself. So looking at actual ulnar nerve lesions, what we want to look at here is what functionality do we lose? So we're going to lose the abduction, adduction of the fingers. Why does this happen? Because we're losing the interosseous muscles. Remember, the interosseous muscles are innervated by the ulnar nerve, specifically the deep branch of the ulnar nerve. We're also going to lose flexion and opposition of the 5th digit. Why? Because the hypothenar compartment is innervated by the deep branch of the ulnar nerve. So all the muscles in that compartment are going to be lost as well. We'll lose flexion of the medial 2 metacarpophalangeal joints. That is due to the lumbricals and that are being lost there. And then we're also going to lose the extension of the 4th and 5th interphalangeal joints, once again from the lumbricals. Okay, so what does that actually look like for a patient? Well, for a patient with an ulnar nerve lesion, they're going to have the presentation that we see here. They're going to have atrophy of the medial compartment of the hand because the hypothenar muscles are not receiving innervation. They're going to have flexion of the proximal interphalangeal and distal interphalangeal joints. And they are going to have hyperextension of the 4th and 5th digits of the metacarpophalangeal joints. So this is the presentation here. Like if a patient presents with flexion of their pinky and ring finger and atrophy on the medial side of the palm, that should indicate that there's likely ulnar nerve lesion that has occurred. All right, and for our last thing that we want to look at is deputrid contracture. This is progressive shortening and fibrosis of the palmar aponeurosis. So the palmar aponeurosis is just, again, fibrous compartments or components of the palm that helps you can contract the palmar aponeurosis via different muscles, and it will help with your grip. But if that fibrosis continues into the fingers and gets onto the tendons, so you're fibrosing the tendons, it can thicken and it can cause the fingers to flex. Okay, so here you have deputrid contracture of the pinky finger on each hand. This can extend, most often it's going to be the 5th digit and the 4th digit that this will occur. So this is deputrid contracture. If you see this progressive shortening and fibrosis of the palmar aponeurosis and it extends to the tendons that go to the digits, you can get this permanent flexion. and that is a surgical intervention that will be necessary to relieve this. So with that, that should bring us to an end of this video.